Hi, good evening and good morning. Dear distinguished guests, Professor Parmar, Professor Zhang, Professor Xu, and all of panelists. It is my great honor to welcome you all to join PCR webinars focusing on prevention of PVL post-TAVR procedure. So today we have a wonderful panelists. We have Professor Parmar. He's a famous cardiologist from Poland. So today he's going to share us with transcatheter aortic valve sizing in challenging aortic anatomies, experiences from Europe. Also today we have Professor Zhang from China. So he's going to share a recorded case with us. Professor Xu from Shenyang North Military Hospital. He's going to chair the discussion on the sizing strategy. So my name is Wang Jian. I'm from Second Affiliate Hospital, Zhejiang University School of Medicine. So I'm going to do a presentation about how to minimize PVL post-TAVR procedure, especially experience from China. I would like to thank you all, especially the organizers, for your hard working to organize the session. So now we welcome Dr. Parmar to deliver your presentation. Welcome you.
你好, I have this great opportunity and the pleasure to be with you and to connect the experience of Europe with China. And I hope we'll provide the good insight for the audience on how to tackle difficult anatomies. And I will present you what I have learned from my masters and tutors here in Poland, and helping to tackle strategies, to develop strategies to provide safe TAVI to our patients. What I will discuss about, and I would also like you to participate in the chat and ask us questions, will be 4 topics. The first one will be bicuspid aortic valves, which are quite common here in Poland, up to 20% of TAVI screened patients, while in China it is much more, and this is why we can learn from the Chinese professors, operators, about this topic. Also how to tackle large annuli, heavy calcification, and also what to do in cases when the annulus size is in between of using different TAVI device sizes. So the most important step to provide a very safe approach to TAVI in our patients is CT imaging. As you can see, we have learned that still images are not enough to screen our patients, and what we do is actually trying to review the CT to define on the anatomy. What you have seen was the patient with a bicuspid aortic valve, and in order to offer our patients a safe treatment, we need to learn how to communicate and how to classify this bicuspid aortic valve. Usually the most common classification is the Sievers one. However, there was a move from the European Society to provide a nomenclature which is based on the classification on how many leaflets there are in the aortic valve, how many sinuses, and also how many raphes which are connecting the fused leaflets. So this means it is quite descriptive in analysis, which is clearly defining the number of sinuses, leaflets, and the raphes. Also, what we have learned is that we scroll through the aortic root using a so-called circle method, meaning that with still images, we present the cross-section of this aortic valve and aortic root every 3 millimeters in order to detect the anatomy of the aortic valve and also to see the calcification. And we try to adapt the chosen TAVI device into this aortic root. And what we've been doing for the past at least 5 years in our center in Katowice in Poland was choosing the SAPIEN 3, and nowadays, since 2 years, the SAPIEN 3 Ultra for bicuspid aortic valves. The reason was that with the SAPIEN 3 Ultra, for the devices sizes 20, 23, and 26, we have improved and higher sealing skirt, which is better than the previous one from SAPIEN 3. And this is how we try to offer our patients a reduced rate of paravalvular leaks, also sealing the bicuspid anatomy well. What we also need to do using these devices is to choose the proper sizes. And how to do this? We try to target these patients according to the annulus size, but we keep in mind that bicuspid aortic valves are atypical, in meaning that the sizing chart may be a bit different from what we have for normal aortic valves. This also means that in cases like severe annular calcification, narrow roots, narrow STJ, narrow LVOT, and bulky leaflets with low coronary ostia, we tend to choose, whenever we have any doubts, we choose a smaller size of the balloon expandable valve, and we try to overexpand it. And this approach, we are checking every 3 millimeters, as we shown here, by doing this Sertl method analysis. So what we also learned is that with SAPIEN 3 Ultra, in comparison to the SAPIEN 3, we may bring down the rate of paravalvular leaks, as you have seen, you can see from this publication from the last year. And also, what we know is that oversizing a smaller size of the SAPIEN 3 and SAPIEN 3 Ultra provides better gradients than choosing a nominal or larger valve to the same even tri-leaflet normal aortic valve, but still in precisely for the bicuspid, this is our default strategy, to choose a smaller size and overexpand it. And we also know that we can do it safely, providing reduced rates of paravalvular leaks and also at least comparative gradient to nominal sizes of the valve. And this was the publication from New York published last year. So to give you an example, this was our patient treating this year with a serous type 1 with a fusion between left and right raphe. With an international consensus coming from Europe, it would be classified as a patient with 3 sinuses, 3 leaflets, 1 calcified raphe with a fusion between left and right leaflets, and the aortic annulus size of 6, 7, 8 millimeters square. We also check the commissural distance, which is about 30. And just to give some insight to the operators, you can see that quite often with the bicuspid valves, we choose the overlap not between the sinuses, but we try to overlap commissures, as you can see on the right side. And this approach gives us a good projection to cross the valve and also to appreciate and just to describe the expansion towards the fusion, which is between the left and right leaflets and will be on the right hand side of the panel. So we always use this projection for the bicuspid approach. Also, what we advised was the screening, the circle method screening to choose the proper size of the device. As you can see on the right panel, this is the SAPIEN Ultra 29, which is being simulated. And now it will be the SAPIEN Ultra 26, which actually adapts quite well in this very calcified anatomy. And with a proper expansion rate, it may offer probably a better choice, avoiding left main occlusion or also improper expansion of the nominal 29 valve. So here you can see on this left video, the crossing with the wire using this commissural overlap projection, which is quite often the left and right overlap projection. And as you can also see on the right panel, a very high position of the SAPIEN 3, which is done on purpose because we need to provide the sealing skirt very high in the annulus level. So here on the left, you can see the implantation with a plus 3 milliliters injected into the SAPIEN 26 valve. And you can also see our standard practice is the pacing on the left ventricular wire, which we do almost in every cases. And this is the final result in this patient. Another patient is a patient with a large aortic annulus and high calcification, as you can see on this CT scan. And we quite often find these patients also within the bicuspid population, because it has been proved that bicuspid population has a preponderance of a large annuli, that the outcomes of using balloon expandable valves within these population is optimal, and that we can increase the expansion of the, let's say, sapien 29 in this population, as you can see on the right lower panel, with up to 5 centimeters cubic milliliters to provide a full sealing. In order to tackle this anatomy, what we need to know is that we want to take time crossing the valve. Sometimes we use the Emplitz left one and pigtail. We do balloon valvuloplasty in case of severe calcification to avoid any problems with the valve passage. And also what we use is using additional contrast with a high supraannular sealing of the skirt, meaning that we always put the marker in the bicuspid valves quite high. And this is the crossing with this overlap of the commissures in this patient. Also, the central marker is positioned higher than the annulus in this patient. And we have prepared, this is the left ventricular pacing with a Lunderquist wire, as you can see on the left, which provides enough pacing to do the left ventricular pacing. And we inject +2 milliliters inside this balloon to provide the full expansion and sealing in this patient. As you can see on this panel, the echocardiography shows lack of paravalvular leaks and also optimal gradient in this patient with the oversize. So the final messages from our center would be that we can target difficult patients with bicuspid aortic valves, large aortic roots, significant calcification, and borderline size annuli if we do a very careful screening of the CT, and also that we know that we can oversize the balloon expandable valves in patients with large annuli, but in cases of high calcification or very narrow intercommissural diameter, we can oversize a smaller valve to provide full sealing and lack of complications. Thank you for your attention.
Hi, Professor Palmer. Thank you so much for your very informative and educational presentation. So we can have a discussion. So or we just let Dr. Zhuang to deliver the case, then we have a discussion after his presentation.
I will be happy to
wait. Okay, Dr. Zhuang, please. We just following the schedule. Okay.
Okay, thank you, Professor Wang, and good afternoon to Dr. Palmer, and good evening for my colleague in China. I'm Dr. Zhuang from First Ability Hospital of Sun Yat-sen University. And so I will share a case we just conducted 2 weeks ago. It's bicuspid aortic stenosis case, also with borderline annular areas. So this is touch 2 issues that Dr. Palmer just gave us the 4 issues, so 2 of it. So we treated with the Sapien 3, but we do not have the actual, so it's just a normal Sapien 3 case. So this is a 17 years old female and very low body weight. The BMI is 19, and she admitted to the hospital because of short breath on exertion for 2 years. And the echo shows the preserved ejection fraction of 16.6%, and the AVO is 0.54 square centimeter. And the peak gradient is 129 millimeter of mercury, and mid gradient is 18.6 millimeter of mercury, and the jet velocity is reached to 5.6 meter per second. So echo shows a severe aortic stenosis with only mild regurgitation, and also mild to moderate mitral regurgitation. And we do angiography, shows only my stenosis in LAD, and base ECG is stenoreason without significant arrhythmia. And also, according to the STS and Euroscope, this patient is only rated to low risk for surgery. And we can see from the video here, this patient after the CT scan is type 0 bicuspid, and it's eccentric. And also we can see it's very the calcification is very heavy, locating only on one lead on the right side of the cups, and is eccentric. Also, the lead is very thickened, and the area, annular area is 358, and also the LVOT is larger than the annual area. And we can see from different the other diameter, the SDJ is not lateral, and the height is acceptable, and the sinus of the Vasava is 21 and 31 on the diastolic phase, and both the coronary height is enough, so it's not a high risk for the coronary occlusion, and also it's not horizontal root angle for this patient. So we'll consider this patient is not that anatomy challenging case, but the calcified locating only on just one lead, and also a BAV may be the major challenge for this case. So in China, when we do a cell expandable valve, we don't do the circle method, but it's popular when we do SAPIEN 3. So every case we will use the SAPIEN 3 methods to do it. So this is a borderline, and also is a bicuspid aortic valve. So it's just between 20 millimeter SAPIEN 3 and 23 millimeter. So using the circle ring, we can see it in most of the levels. We can see maybe 23 can seal better, much better to the valve. But when we look at the 6 millimeter and 9 millimeter about the annulars, we can see that the ring 20 millimeter SAPIEN 3 or 23 link, there may be under expansion on the right side of the cups because the calcifies there. So here is the question: should we use the 20 meter and then plus 1 or 2 millimeter to deprice the valve, or maybe 23 valve, and then maybe minus or nominal to minimize the PVL. So after the discussion with the teams, we consider the 23 with underfilling, maybe -1 or -2 is a better choice for this patient because it is a relatively young female. So she might have another redo TAVI 10 years later. So if we just deploy 20 SAPIEN 3, he will lose the opportunity to do it. And also we can see the calcify only locating on the lead left, no on the commercial, and no fields or buckles calcify. So it's a low risk to for rupture. So also safe for us to give a larger valve there. And also the CT scan is on the diastolic phase. So the area, the annular area, so might be underestimated. So we still waiting for maybe there is a good one, maybe a larger area for us to open the opportunity for 23. So just to minimize the PVL, this is the major focus. So 23 minus underfilling -1 or 2. So we'll also do predilation using the balloon to get more information and to see after the ballooning where the weight is and any leak there. So this is the plan. And the femoral access is acceptable. So before the procedure, there are some consideration here because this is a BAV case. So the coplanar views is also a challenge for us to get a good one. So we might, in some cases, we might consider using the double p-tail strategy to adjust the coplanar view. But if we cannot do it, it's not necessary for us to to do it, but we can optimize the view here. So the coplanar view is easier. And also in some case, we use SAPIEN 3, we won't do predilation. But for this case, we will choose to do predilation. First, to just make sure the device to close the valve easier. And then we'll use the 20 millimeter balloon just also to verify the true size of the valve. And also we already discussed before the which size should we choose, the valve 23 or just 20. We'll stick to our the first plan, use the 23, maybe -1, but will depends on the information we can gain from the predilation. And also in China, in the BAV case, for the self-expandable valve, we'll focus more on the superior annular structure. So sometimes we'll downsize and then very high implant to minimize the PVL. But I think for the SAPIEN 3 is also the superannual theory income sets is also reasonable, and we try to high implant with the 19 and 10 position. I can see just Dr. Palmer, your case is also very high implant SAPIEN 3, so it's a good result for this patient, maybe the good result for this patient. So this is the coplanar view. We tried to do the double pigtail strategy, but we failed because this is not horizontal one. But when we put another pigtail, I don't think it's helpful for us to adjust this view. So we just stop that. And also the Y crossing is not challenging, but we can see that only both the lid left is moving, and the calcifies on the leg cups, it also can move, but it will raise issues after when we try to exchange the pigtail. So when the wire crossing going to the left ventricle, we try to exchange the pigtail. It just pull back by the pigtails because it's tortured by the calcifies on the valve. So we do the wire cross again. Also use the super stiff to adjust the Y positions. And usually for SAPIEN 3 case, super stiff is enough. But when we adjust it, it looked very ugly. So I think it's difficult when I put the balloon or maybe the valve. So we change to Lennon-Quist wide. And after we change to Lennon-Quist while I think the position and the why it look better than the super stiff. So after we change Lennon-Quist, we can do it very smoothly. And here's the dilation. You can see that it's not a good one, but we can see there only a little bit weight on the very heavy calcified points, and there's no significant leak there. So 23 - 1 is reasonable for this case. And then there's the alignment, well alignment, nothing special. And also closing the X for SAPIEN 3, I think it's easier for this case, not horizontal. The arc is not very wide angle for this case. And then it's the position. We focus more on this position because we decide to put it high implant. So we use before the rapid pacing, we use the contrast to decide it. And then on the right video, we can see we just after rapid pacing, the position is okay. So we deployed it only -1. And we can see more detail here. After the fully expansion of the balloons, the weights on the left cups, right? The LCC cups, I think the weight it looks smaller, but after the inflation of the balloon, so the under expansion points also still happens there. So this is the final result. So here's another question we need to discuss during the procedure. Should we to do post-dilation, maybe with nominal burden, or we just accept this result? So after the discussion on the cath lab, I think this result is quite okay because we can see that under filling 1 millimeter, the PVL is only trace, and also the gradient is not larger than 10 millimeter of mercury. And also, I think if we use a larger balloon or just nominal balloon, it can't change anything. It just still will have the under expansion points there. So this is the final result. And also, we can see here is the heavy calcified there. I see a similar video just on Dr. Palmer's. You just show us another case here. And also the final result, you can see the co-acidity is acceptable, is 1820 and 1910 positions on both sides. So we just finished this procedure. And after that, we do the echo to evaluate the PVL, and we only see the minor or trace PVL. So here's this case, and we check the SS is okay. So this is not the point. So here's some tail messages. Before we decide which one or which size of the valve we should choose, maybe we not only just decide on the anatomy consideration, maybe the patient's age, and also for the change of PVL and the rupture of the coronary risk, occlusion risk, and all of this we should evaluate comprehensively. But for the borderline BAV case, if we only focus on the anatomy consideration, maybe the supraannular sizes, and we do the CT scan, focus more on the circumferences, and sometimes we'll do high print on this case. And also sometimes we need to borrow the landing quiz to get us more support because we don't usually use this on Sapien 3 case. And also balloon sizing or predilation is important in this BAV or borderline case. We can get a lot of information on this balloon sizing field. Also, I need to ask the question, maybe we can discuss later, a larger size with underfilled or the smaller size valves with oversizing balloon, which one is better? But this case, I think, is a younger patient. I would like to put it a larger size for a valve for this patient because he might do another TAVI again, maybe 10 years later. So yes, the case. Thank you all.
So thank you, Dr. Zhuang, for your excellent presentation, excellent case presentation. Now, Professor Xu, please chair the discussion.
Thank you, Professor Wang. Dr. Palmer and Dr. Zhuang gave us 2 wonderful lectures. I learned a lot. I think we have a lot of things to discuss. But I think the most important one is how to, for the first part of this webinar, is how to sizing the valve. So my question is how to balance the risk of, for example, annulus rupture and long-term outcome in those patients. I think the most important is the bicuspid patients because they have more complex anatomy. And how to choose, should we choose the smaller valve or the larger valve? Is really a very important question. I want to hear the experience both from Europe and China in your clinical practice. What kind of strategy you really use in bicuspid patient to choose the valve size, especially for the balloons expandable valve? Thank you so much.
I was looking at this procedure with a wonder because actually it shows several things. The first thing is the differences between Europe and the United States in comparison to the Asian population in terms of the anatomy of the aorta in our patients. We usually have patients with much larger sizes of the aortic root than the case presented, And this actually poses the problems whether to choose the smallest valve possible or whether to implant the larger valve, which is a bit downsized, to guarantee larger valve orifice and then to decrease the gradients. Also, it shows how we want to avoid the rupture of the annulus with a 23 and balancing between the 20. So what I would do is follow the presented circular method to simulate the valve between the 20 and 23, to have in mind that we can expand the size of the 20 millimeter using additional 2 milliliters, and to guarantee proper expansion with no central regurgitation between the leaflets, and also minimizing the risk of pacemaker because the lady was 71, so we would like to avoid it, and also to offer this patient low gradients and also a low probability of bad coaptation, because we need to have in mind that in unexpanded valves, the probability of degeneration may be larger. The benefit of using the 23 is, of course, that during this implantation, we may post-dilate. And this makes us also have in mind whether we will decide on infusion on of larger amount of contrast within the commander system, or we have non-compliant balloons in place. And we should have, and this is how we try to manage this. In case of any irregularity of expansion, we would post-dilate the 23 millimeter valve. There was also a question from the audience in the chat, which balloon size we should choose, whether it should be 20 or 23. And this I would give it to Dr. Zhang, because it actually, with a 20, it may seal well, and this indicates a smaller valve. If it does not seal well, then we would go with a larger valve. So what's your decision?
Okay, thank you for the question. So about which balloon we should choose, the 20 and 23, I think it depends on the why we use the balloon for only for sizing or to evaluate or for the coronary risk, occlusion risk, or maybe just to make the device close easier. So if we just want to get the device easier, so any balloon I think is okay. But for some case, if we want to evaluate, sometimes we'll use the smaller one. If let me choose 20 or 23, if I choose 20, my consideration usually is like this. If I use 23, but it had a waste, sometimes they lost the opportunity to downsize because you will already choose the a bigger balloon, already maybe disrupt the supraannular structures. So left us no choice, we can only choose a larger one. But if I choose the 20 meter balloon, maybe I can still maybe choose another one, a larger one, or I just use the larger valve. So it's a little bit, I would choose the just a balanced one, so a smaller one, 20 millimeter to evaluate or to do the sizing. But if we need to also, after both sizing and to evaluate the coronary risk, sometimes we need to choose a bigger balloon. If we choose the smaller one, it's not enough for us to evaluate the coronary risk. So I think just a trade-off. Maybe this patient is a high risk for coronary risk occlusion, so I would choose the big one. But if we don't only do sizing, I would choose only maybe balanced ones, not the smaller. But I think it's enough for us to make the decision. Is okay. Here's my thoughts. Thank you.
Yeah, I think balloon sizing is a very important question. So I want to ask the Professor Wang, because for the self-expandable valve, we use a lot of Hangzhou experience in China, also in our center. I think it's very important to choose for the self-expandable valve size. So could you tell us your experience to use balloon sizing in the balloon expandable valve? Thank you.
Hi, thank you, Dr. Xu, for your question. And actually, when the patient has a different anatomy, we may use a different strategy. So when we treat the patient with very severe calcification, so especially with the bicuspid aortic valve stenosis, we cannot open the superior annular structure or the native valve leaflet, open it so wide as the annular size. So when you when you use the regular size of device, the supraannular structure will squeeze the device, either compress the device or even cause the device diving into the left ventricle, or maybe pump out. So very important, we need to understand which part of the anatomy, which part of the site, which anchor the device. So oversize or downsize. Now, usually when we do downsize, so now means actually compare with the supraannular structure, may not means you really downsize. Maybe it's a proper size because of the anchoring site in the supraannular structure, by the supraannular structure. So for most of the patients with tricuspid valve leaflet without severe calcification, sure, the annular sizing strategy is very important because always you can open the native leaflets wide as the valve ring. So no problem. You need to oversize the device. You need to select the oversize. So I would like to get the comments from Dr. Palmer. So what is your comments about the supraannular structure, especially the native leaflets? Maybe two types of device are a little bit different. Actually, the balloon expandable device has much stronger radial force than the self-expanding device. But even for the balloon expandable device, like the case that Dr. Zhuang showed us, still the device be compressible by the very severe calcified structure above the ring.
Correct.
So what is your comment?
My comment is that we also used, and we are still using, self-expandable devices in bicuspid anatomies. We used to use also mechanical expandable valves. And what we learned to do is, first, that of course we need to be able to fully open this bicuspid valve and to guarantee low gradients in these patients, because usually these patients are younger. If they can't undergo surgery, then we need to take care and think about the opportunities in at least 10 years to go. But what we also learned is that we can fully open this very calcified valves with a balloon expandable valves, and then we can also guarantee a second intervention, so re-intervention, let's say 10 years later, with good coronary access. So actually, what we are doing nowadays, especially in patients with a small aortic roots, is that we choose the balloon expandable valves on purpose because we can already forecast that there will be a need to implant a second valve in, let's say, 10 years or 15 years ahead, which the patient is expected to survive. So this is actually the reason why we chose this strategy. But of course, especially with hugely calcified aortic anatomy, we are sometimes very prone to speaking to the surgeons if they can operate this patient more effectively. And I think that this talk between whether to do TAVI or surgery is much more frequent than choice of the selection of the valves, because we know that we can offer the treatment sometimes comparably. But I would just stress that very calcified anatomies in very young patients still should be considered operative.
Okay, when you treat your patient with the sapien 3, do you regularly do the balloon valvotomy?
Yes, we do, especially when there is a lot of calcification and the stenosis is predominant. So I think that we target about 1/3 in our center of these patients with a balloon predilatation. To beginning centers, we advise to do it regularly in all patients, because we need some strategies in case we do not cross with a balloon expandable valve. So we need to have another access available to predilate from another route. So this is only this advice. But frankly speaking, the Commander system gives us enough push to tackle all bicuspid anatomies we have. Type 0 is maybe the most tricky one, in which we need some talk.
Okay. I think from our view, from our point of view, the balloon sizing is very important for the patient with severe calcification and the bicuspid aortic valve stenosis. You know, the CT sizing is not so precise because from the CT we don't know how strong the resistance. So coming from the calcified tissues. So when we use the balloon sizing, we know how big resistance. So we know what is the true diameter of the native valve at last. So just now, okay, you know, even in China, even in the older patients, about 75 years old, still 20 to 30% of patients are bicuspid patients. So that means the young, you know, even the older patients, there are higher percentage of patients with bicuspid than the Western population. So most of them may still cannot be operable or even high risk for operation. So we still have to deal with this kind of patient with TAVR.
So this is actually the reason why I think that such opportunities to meet and exchange this practice between Europe and China are important, because we need to learn from you. And what I can only tell is that in patients with who have small STJ, so that means that we are afraid of putting a larger valve, and also it may cause a self-expandable valve, supraannular valve, under expansion of the frame. These are the patients in whom we do sometimes the balloon sizing using the balloon inserted a bit lower, just to identify how much we can overdilate this anatomy, and which size would be the proper one. So it means when the aortic root is in a conical shape and with the STJ not allowing full expansion of the balloon for balloon expandable devices.
Okay, thank you. We learn from each other. Professor Xu.
Okay. Thank you. I think can we move to the next lecture? Dr. Palmer, could you chair the Dr. Wang's lecture?
Yes, I hope that is Dr. Wang with us? Yes.
Yes.
So yes, of course. So I would like now to invite the Professor Wang to talk about the prevention of the complications which we have with using currently available TAVI systems to prevent paravalvular leaks. This is especially important to prevent it in patients with bicuspid valves, which may be younger, but also with patients with a lot of calcifications which we see. So we will be happy to learn from you how to avoid it.
Hi, thank you, Dr. Palmer. Okay, so I'm Dr. Wang from Hangzhou, China. I don't have any disclosure. Here's the topic I'm going to cover. First one is about the impact of PVL after the TAVR procedure. From many studies, we know severe PVL is strongly related to the worse outcome, including mortality and hospitalization for heart failure. So, so even mild PVR was associated with an increased risk of mortality at 5 years. So how to predict predicting PVR? So just now, Dr. Parra also mentioned about unfavorable anatomy and device type and the size, and suboptimal implantation depth. So what are unfavorable anatomy characteristics? So the extensive and uneven distribution of calcification. So it's a big challenge, which may cause the PVL. Also a bicuspid aortic valve, especially the type 1 with red feet. Regularly, generally speaking, the bicuspid aortic valves stenosis have more severe calcification. Also for this patient with a very big aortic angulation. Why is okay? So what is about the device type? From some papers, from some studies, looks the CP3, the balloon expandable device, has better performance to prevent the PVL. So like some study, so we can see here from the particle study, so the CP3 has better performance in preventing the PVL compared with the other device, like the scope, like the France timer. So when we compare the partner 3 with the average low risk, so we still can see the looks. So maybe the CP3 has better performance in prevention of PVL. So how to have a proper sizing? Actually, just now we already have a good discussion. But from the 2 papers, so it looks like the oversizing is better for preventing PVL. But we need to remember, so most of the patients enrolled for the 2 studies are tricuspid aortic valve stenosis patients. So for tricuspid and bicuspid, so may have a totally different stories. Also, I think the another important factor is the implantation depth. So if it's too deep, or most commonly is when we deploy the device too deep, so may cause the PVL. How to prevention and management of PVL? So carefully pre-procedure evaluation by multiple slide CT scan. It is very important. The second one is device selection. Some of the newer generation valve may have a better outcome to prevent the PVL. So valve with a leakage-proof function. So appropriate. Okay, back. I cannot back. Okay. Sorry, I cannot go back. So operator, would you help me to go back? Okay, stay here. Go further. Okay, stay here. So appropriate valve sizing and the suitable implantation depth. Okay, next one, please. Here's the 2 example for the balloon expandable device. So how to select the proper size device and how to have a proper implant depth. for a borderline case with a heavy calcification, so the annular diameter is 23.5. So when we do the balloon valvotomy, inflation of the balloon. So we inflate the balloon. We can see. So on the left, we can see the clearly waist there. So means over there the calcification tissue the resistance is very strong. So for this kind of patients, if we implant too big a size device, the device may be compressed. So even you select a big size, that means you achieve a bigger orifice. So for this patient, we may select 23, so 23 millimeter diameter device, the 63. So for the second column, when we do the balloon valvotomy, we can see the balloon is not be compressible, no severe calcified tissue, so which compress the balloon, so no waist sign. So maybe we can select a 26 device. So when you have a downside, when you select downside device, you need to have a higher deployment. You need to have a higher implant depth. So maybe 23 is a little bit smaller. You can add 1 or 2 cc to fill the balloon. So you may still have a good achievement. So for the oversized device, so regularly you may have an anti-feeding 2 millimeter to see what is going on, whether the patient has leakage or not. If the patient without leakage, it should be fine. If the patient with leakage, you may add 1 cc or 2 cc for balloon expandable device. So operator, okay, for the self-expanding device, regularly we design a strategy we call the Hangzhou solution. So we use a balloon valvotomy not just for open the valve, but also the balloon valvotomy also is for the sizing of the structure. So when we regularly we select the balloon size, which is very close to the annular size. So we just do a one-time balloon valvotomy. We don't need to change the balloon size. So we just one-time balloon sizing strategy. So when we inflate the balloon, if the balloon is, we can see a very clear waist sign on the balloon without the leakage. So we can just depending on the balloon size to make a decision how big size of the device we need. So if the balloon, when we inflate the balloon without any the waist sign, so maybe we can just use the annular sizing strategy. So if the patient with waist sign but still have leakage, so regularly during the inflation of the balloon, we do the aortic angiogram. So if we can see clear waist sign on the balloon, but with the leakage, so we still use the annular sizing strategy. So only for these patients, when we inflate the balloon, we have a clear waist sign without leakage of contrast. When we simultaneously we do the aortic angiogram. So we carry on. Operator, could you help me to move the slides? One more slide. Next slide, please. So we designed the RCT study, but now it's still ongoing. So we went totally randomized control study. So we just select the type 0 bicuspid aortic valve stenosis patient, randomly divided into 2 groups. So one group we apply the supraannular sizing strategy. The other group, we use the annular sizing strategy. So we are still waiting for the result. So there is so how to treat the treatment of the PVR? So balloon post-dilatation may function for decrease the PVR severity, either for the balloon expandable device or for the self-expanding device. So my cell phone doesn't work well. Okay. So maybe some delay. So post-dilatation at 1 cc or more, so we achieve a better outcome to decreasing. So here's a flare and a flat inflow technique. Because just now the Dr. Palmer already mentioned about the skirt. So on the sapien 3, so when we try to expand the device, so try to have a flare, so which may prevent or decrease the regurgitation. So keep on going. For self-expanding device, especially for the second generation, we have a very important to remember to retrieve the device and a higher deployment. You may achieve a better outcome. So especially when you have a downside, you select the downside device, especially for the self-expanding device. Very important. Remember, you need to have a higher deployment. So when you use the downside device, higher deployment is very important. Okay. So like the patient, initially we select standard annular size device. So because of the valve leaflet is very thick, sometimes some patient calcification is not severe, but the leaflet is very thick, cannot be open. So the leaflet can squeeze in, because the device is too big, can squeeze in the device down to the ventricle. So now means you select the bigger size, you achieve a bigger orifice, you have a better PPM. Now means that. Now means so proper size is always mostly important. So even sometimes we need to put a vascular plug, even some the umbrella to close the leakage. So prevention of the PVR is most important than put the second valve or to put an umbrella to stop the leakage. So always remember the proper sizing and the good evaluation on the CT scan. Even we use the balloon sizing strategy. So to understand the structure is the most important to prevent the leakage. Okay, so that's my last slide. Thank you all. Thank you for your attention. Please unmute Dr. Palmer. Dr. Palmer, please unmute yourself. Okay.
Thank you, Professor Wang, for such a comprehensive and beautiful presentation on how to address this issue of optimizing the TAVI and also of providing safe and effective approach to patients with not only bicuspid aortic valves. What I have learned recently, I read the consensus paper from China by Professor Yung Wo, and also the Carey registry by Professor Ming Li, which show that the frequency of bicuspid aortic valves is very high in China, and also that in comparison to Europe, the agreement to offer TAVI to younger patients than 75 is wider. And it follows actually the report from yesterday from JACC Cardiovascular Interventions, which show that in isolated aortic stenosis, already the TAVI offered to young patients under 65 reaches 47%. So this makes me realize that we in Europe need to learn from China and currently also US on how to approach these patients effectively and which valve to choose, because we will be expecting them to live for a long time. and we may not allow any paravalvular leaks, coronary risk occlusion, and then also pacemaker rates. So I'm very grateful for meeting you today and also for providing these information to our audience.
Thank you. Dr. Palmer?
So I would like to... So I would like to conclude and thank you, all the faculty, for being with us here today, and also to all the audience for staying with us and learning on the topics on how to decrease the risk of paravalvular leaks and how to treat effectively in the patients with a bicuspid aortic stenosis. And we will welcome you also to review this webinar online at the PCR online. And I hope that we'll meet together at the conferences, but also here on the website. Thank you so much. Shusha.
Thank you, Dr. Palmer, Dr. Xu, Dr. Zhuang. And also thank the operator for your hard working. Bye-bye. See you next time.
Bye-bye.
See you.
Thank you.